In this lecture, we are bringing together 4 disability categories that are sometimes taught separately: other health impairments, orthopedic impairments, visual impairments, and deafness or hearing loss. These categories are different from one another, but they share an important theme. In each case, the student may be fully capable of learning the academic content, but the school environment, the pace of the school day, the communication system, the materials, or the physical design of instruction may create barriers. That distinction matters. A disability category does not tell us everything about a student. It gives us a legal and educational starting point. From there, educators need to ask better questions. What does this student need in order to access instruction? What barriers are built into the classroom or school routine? Which supports increase independence? Which supports unintentionally lower expectations? And when do we need an IEP, a 504 plan, or universal design practices that should already be available to all students? The legal standard under IDEA is not simply whether a child has a diagnosis. The question is whether the disability adversely affects educational performance and whether the student needs special education and related services. Some students with medical, physical, visual, or hearing-related needs will qualify under IDEA. Others may not need specialized instruction, but may still need protection and accommodations under Section 504. This lecture is about understanding those distinctions while keeping the focus on access, participation, independence, and belonging. Part 1. Other health impairments. Other health impairment, often shortened to OHI, is one of the more common IDEA eligibility categories. Under IDEA, OHI involves limited strength, vitality, or alertness, including heightened alertness to environmental stimuli due to a chronic or acute health condition, when that condition adversely affects educational performance. The examples in the federal definition include asthma, ADHD, diabetes, epilepsy, heart conditions, hemophilia, leukemia, sickle cell anemia, and Tourette syndrome. The phrase limited strength, vitality, or alertness is important. A student with OHI may not look disabled in an obvious way. The issue may be stamina, fatigue, pain, blood sugar management, seizures, attention regulation, medication effects, absences, anxiety about health routines, or reduced alertness during parts of the school day. A student with diabetes, for example, may need predictable access to snacks, blood glucose monitoring, a nurse, or bathroom breaks. A student with epilepsy may need a seizure action plan and staff who know what to do before, during, and after a seizure. A student with ADHD may need environmental supports, explicit executive functioning instruction, movement, chunked directions, or structured opportunities to check work. One of the most common mistakes educators make with OHI is assuming that inconsistency is the same thing as lack of effort. A student may perform well one day and struggle the next because symptoms fluctuate. A student may understand the content but have difficulty sustaining attention or energy across a long instructional block. A student may miss school for appointments or illness and then return to a classroom that has moved on. The educator's task is not to decide whether the need is convenient. The task is to design routines that maintain access and dignity. Supports for OHI often include flexible scheduling, planned rest breaks, medication management, seating decisions, reduced environmental triggers, access to the nurse, healthcare plans, emergency plans, and communication systems between home and school. When the student needs specialized instruction, such as explicit executive functioning instruction, adapted academic routines, or special education support to access the curriculum, an IEP may be appropriate. When the student primarily needs accommodations but not specialized instruction, a 504 plan may be more appropriate. Part 2. Orthopedic impairments. Orthopedic impairment is a low-incidence IDEA category, but it is extremely important for educators because it pushes us to think carefully about physical access and participation. IDEA defines orthopedic impairment as a severe orthopedic impairment that adversely affects educational performance. The definition includes impairments caused by congenital anomalies, disease, or other causes, such as cerebral palsy, amputations, fractures, burns that cause contractures, spinal cord injuries, or other conditions that affect movement, posture, coordination, or physical functioning. A student with an orthopedic impairment may use a wheelchair, walker, braces, crutches, prosthetics, or other mobility supports. But again, the device does not tell the whole story. Some students may have fatigue, pain, muscle tightness, limited fine motor control, speech differences, positioning needs, or healthcare routines. A student with cerebral palsy might need support for mobility, writing, posture, communication, or self-care, but cognitive ability can vary widely. A student with juvenile arthritis may have strong academic skills, but experience pain, stiffness, or fatigue that affects handwriting, transitions, attendance, or participation in physical education. When we think about orthopedic impairments, we often jump immediately to ramps. Ramps matter, but access is much broader than ramps. A student may need a desk that fits a wheelchair. They may need clear pathways through the classroom. They may need accessible restrooms, an elevator key, adaptive physical education, extra time for transitions, digital note-taking, speech-to-text, or an alternative way to participate in labs, art, music, or field trips. The question is not only, can the student enter the room? The question is, can the student participate meaningfully once they are there? Teaming is essential. The general education teacher should not be expected to solve every access issue alone. Students with orthopedic impairments may work with special educators, physical therapists, occupational therapists, adaptive physical educators, nurses, speech-language pathologists, assistive technology specialists, transportation staff, and family members, but the student should also be part of the planning whenever possible. Students often know which routines support independence and which routines make them feel singled out. The most inclusive support is not always the most adult-dependent support. For example, assigning an aide to do everything for a student may help in the short term, but reduce independence and peer connection over time. Good support asks, how can we remove the barrier while preserving student agency? Sometimes that means adjusting the environment. Sometimes it means using technology. Sometimes it means changing the timeline. Sometimes it means teaching peers and adults to wait long enough for the student to respond, move, communicate, or complete a task independently. Part 3, visual impairments. Visual impairment, including blindness, is also a low incidence category under IDEA. The definition includes an impairment in vision that, even with correction, adversely affects educational performance. This includes both partial sight and blindness. It is important to note the phrase, even with correction. A student who simply needs glasses does not automatically qualify under this category. The educational question is whether vision continues to affect learning after typical correction and whether the student needs special education or related services. Visual impairment is not one single experience. Some students are totally blind and receive no useful information through vision. Some are functionally blind and primarily learn through tactile and auditory channels while perhaps using limited vision to support movement. Others have low vision and use vision as the primary means of learning, but need enlarged print, magnification, contrast, lighting, positioning, or assistive technology. Two students with the same label may need very different supports. One key idea is that vision supports incidental learning. Sighted children learn a great deal by watching what happens around them. They see how people use objects, how people move through space, what facial expressions mean, where materials are located, how far away something is, and how parts fit together. Students with visual impairments may need more explicit instruction in concepts that sighted peers pick up casually. This can include spatial language, object properties, orientation, social cues, diagrams, maps, scientific models, and functional life skills. Age of onset also matters. A student who loses vision later may have a large bank of visual memories and concepts. A student who is blind from birth may have built knowledge primarily through touch, sound, movement, language, and direct experience. Neither student should be treated as less capable, but instruction must be designed around how the student builds meaning. Supports may include Braille, tactile graphics, screen readers, refreshable Braille displays, audiobooks, large print, magnification, computer accessibility tools, high contrast materials, orientation and mobility training, functional life skills, instruction, and accessible classroom routines. Low-tech supports also matter. Proper lighting, glare reduction, uncluttered materials, consistent placement of objects, verbal descriptions of visual information, and enough time to access materials. A common mistake is to make visual information central to a lesson without offering an equivalent path into the concept. If a teacher says, "Look at this chart and tell me what you notice," the student with low vision or blindness may be excluded unless the chart is described, converted into tactile form, provided digitally in an accessible format, or explained through data in another mode. Universal Design for Learning asks us to plan those pathways in advance. Students should not have to wait for access after the learning moment has already passed. Part 4, Deafness and Hearing Loss. Deafness and hearing loss involve access to sound, language, communication, and identity. IDEA distinguishes between hearing impairment and deafness. Hearing impairment means an impairment in hearing, whether permanent or fluctuating, that adversely affects educational performance, but is not included under the definition of deafness. Deafness means a hearing impairment so severe that the child is impaired in processing linguistic information through hearing, with or without amplification, and that adversely affects educational performance. Hearing loss can range from mild to profound. A student with mild hearing loss may hear many speech sounds at close range, but miss information when there is background noise, distance, fast speech, or overlapping conversation. A student with moderate hearing loss may miss parts of words or certain speech sounds. A student with severe or profound hearing loss may access language primarily through sign language, captioning, interpreters, tactile supports, visual cues, technology, or a combination of communication methods. One important point is that amplification is not the same as typical hearing. Hearing aids and cochlear implants can provide access to sound for many students, but they do not automatically remove every communication barrier. Classrooms are noisy, teachers move around while talking, students talk over one another. Videos may lack accurate captions, directions may be given while students are packing up. A student may appear to hear because they respond sometimes, but they may be filling in gaps, lip reading, watching peers, or missing incidental information. Educational approaches vary. Some students use oral approaches focusing on spoken language and listening. Some use total communication, combining speech and manual communication. Some use American Sign Language, which is a complete visual spatial language and is central to deaf culture in the United States. Educators need to be careful not to treat ASL as a lesser version of English. It is a full language with its own grammar and cultural significance. Supports can include hearing aids, cochlear implants, FM or DM systems, interpreters, captioning, speech-to-text, visual alerts, preferential seating, written directions, vocabulary preview, checking for understanding, and careful turn-taking routines during discussion. But good support is not simply giving the student a device. Access requires classroom habits. Face the class when speaking. Do not talk while writing on the board. Repeat or paraphrase peer comments. Caption all videos. Provide key vocabulary in writing. Reduce background noise when possible. Make sure emergency announcements and classroom transitions are visually accessible. As with visual impairment, incidental learning matters. Students who are deaf or hard of hearing may miss hallway conversations, quick side comments, jokes, peer interactions, or teacher remarks that were not directed at them but still carried important social or academic information. Teachers can help by making expectations explicit, using visual routines, and ensuring that the student has full access to both instruction and classroom community. Part 5, the Shared Framework, Access, UDL, IEP, 504, and LRE. Across all four categories, the central question is not, what is the label? The central question is, what blocks access to learning, communication, participation, safety, independence, or belonging? OH, I may require attention to stamina, health routines, and fluctuating performance. Orthopedic impairment may require physical access, assistive technology, positioning, transportation, or transition planning. Visual impairment may require tactile, auditory, digital, and environmental access. Deafness or hearing loss may require language and communication access. Universal Design for Learning is the first layer. That means designing lessons with multiple ways for students to receive information, engage with ideas, and express learning. For example, a teacher can provide directions verbally and in writing. A teacher can caption videos for everyone. A teacher can make materials available digitally before class. A teacher can allow students to respond orally, in writing with technology, or through a structured visual product. These practices help students with identified disabilities, but they also help English learners, students with temporary injuries, students who were absent, students with anxiety, and students who simply benefit from clarity. Individualized accommodations and services are the next layer. Some students need support that is specific, documented, and legally protected. An IEP is appropriate when the student qualifies under IDEA and needs special education and related services. A 504 plan is appropriate when the student has a disability that substantially limits a major life activity and needs accommodations, but not specialized instruction. Both are important. Neither should be treated as a consolation prize. The plan should match the need. Placement decisions must also begin with the least restrictive environment. That means we do not begin by asking where students with this category usually go. We begin by asking what supports would allow this student to be educated with non-disabled peers to the maximum extent appropriate. Some students need consultation. Some need in-class support. Some need pull-out services for specific instruction. Some need specialized settings for part or all of the day. But the category alone should never determine placement. The takeaway from this combined lecture is that access is an educational responsibility, not an act of kindness. Students with health, orthopedic, visual, or hearing-related needs are not problems to be worked around. They are learners whose access needs reveal how flexible, inclusive, and thoughtful our systems really are. As a community, we should learn the definitions, but we should not stop with definitions. We should notice barriers, listen to students and families, collaborate with specialists, design with UDL, document needed supports, and maintain high expectations. The goal is not simply to help students get through school. The goal is for students to learn, communicate, move, participate, and belong with dignity.